Hello and a warm welcome to all of you from Docplexus. Thank you all for joining us in celebrating our 9 glorious years celebration at Docplexus last month. Today, I welcome you all in celebrating the World Diabetes Day here and be part of Docplexus Global Diabetes Summit 2022, which is a 3-day clinical discourse organized from 12th November to 14th of November 2022. Global Diabetes Summit 2022, we shall discuss and tackle the largest and the most affecting non-communicable disease of the world, diabetes. Currently in India, 77 million people are affected with diabetes, which makes it the second most affected country in the world after China. The International Diabetes Federation has projected the number to grow to 134 million by 2045. Out of the 77 million diabetic patients, 60% are being treated with oral hypoglycemic agents, 25% are being dependent on insulin, while about 7% are being treated with injectable GLP-1 analogs. Interestingly, among children, according to a study published in Indian Journal of Endocrinology and Metabolism, it is estimated that India is home to about 97,000 children with type 1 diabetes mellitus. Hence, Docplexus brings to you the Global Diabetes Summit 2022. Today, on the third day of Global Diabetes Summit, we had expert roundtable discussion with renowned international and national panelists discussing the latest development in the management of diabetes. I shall now present to you another panel for discussing the holistic management of diabetes. For moderating the session on holistic management of diabetes, firstly, let me introduce Dr. Rahul Desai. Dr. Rahul Desai is a consultant diabetologist at Advanced Diabetes Care, Valsad. Dr. Desai, if you could please moderate the session further.
Good evening, everyone. First of all, I would like to thank Docplexus for giving me this opportunity to moderate today's session. I welcome all the doctors for this interesting and engaging session, the holistic management of diabetes, with an esteemed panel as a part of Global Diabetes Summit 2022 on the occasion of World Diabetes Day. Let me start by introducing today's panel. Firstly, Dr. Bansi Sabu, diabetologist and endocrinologist, chairman at Diabetes Care and Hormone Clinic, Ahmedabad. Next up, Dr. Usha Sriram, American Board Certified Endocrinologist, diabetologist and endocrinologist at VHS Hospital, Chennai. Dr. Brij Mohan Makkar, Senior Diabetologist and Obesity Specialist, Dr. B.M. Makkar, Diabetes and Obesity Center, Delhi. And last but not the least, Dr. Alok Modi, Consultant Physician and Diabetologist and Medical Director at Dr. Modi's Kevalya Hospital, Mumbai. Since ADA guidelines have also promoted the use of SGLT2 and GLP-1 analogs, how do we make the decision between using these two molecules based on patient profiles?
Very good question and very clinically relevant question which you had asked. How we decide GLP-1 versus SGLT2. Both these molecules are cardioprotective. They are also beneficial in patients with renal failure. And both of these molecules, as per our ADA ESD guidelines and the evidence, that a person with a comorbidity, particularly with cardiovascular disease, either of these molecules should be chosen. Now, one is injectable. Now there is an oral GLP-1 is also available with us, and other is in tablet form, that is SGLT2. And luckily now it is available after off patent of dapagliflozin at a price of almost 10 rupees or 15 rupees per tablet. Now, if you see, both these molecules reduce the weight, but the significant weight loss is more with the GLP-1 analog. In my clinical practice, I find if a person with a established cardiovascular disease, but more with a heart failure or a renal failure, my choice will be SGLT2 inhibitor. But if person with atherosclerotic cardiovascular disease, not with heart failure, because coronary artery disease, particularly the further progression and events of CAD are significantly reduced by GLP-1. But again, it also depends on the acceptance of the patient because it is in injectable form. Even if it is in oral form, the cost is a major hurdle for many of our Indian patients. So I decide either of these two molecules to the patients depending on the comorbidity. It is heart failure or renal failure more with SGLT2. It is only with the obesity, weight management, and as an anti-atherosclerotic agent, I would like to use GLP-1. Then cost also comes in between. And if patient is not affording or he is not ready to take injectable form or even the oral form, which is a very costly molecule, or it is to be taken early in the morning, empty stomach, if patient is not ready to take, then yes, we may go for SGLT2. One more GLP-1 side effect, you can say slightly heaviness is a challenge. And similarly with SGLT2 inhibitor also, there is a challenge of genitomycotic infection. So with the side effect profile, with the comorbidity and the cost, all three are major, I can say, factors which can decide between SGLT2 or GLP-1.
Thank you for that question. It's an important decision. So SGLT2 inhibitors are all oral, anti-diabetes medications. And oral is always a lot easier to prescribe when it comes to compared with an injectable. So the first decision is that. The second thing is SGLT2 inhibitors have pretty much, they and the GLP analogs are now considered that we should consider them when a patient with type 2 diabetes has ASCVD, atherosclerotic cardiovascular disease, or kidney problems. So after metformin, lifestyle modification and metformin, this is the next agent that we are supposed to go with. That's what the guideline says. So SGLT2 inhibitors are and empagliflozin is the first drug that actually came out and said that there is you could use it for, especially for as a secondary prevention agent in people with cardiovascular disease. It improved mortality, and it also has proven to be very, very good for kidney disease. So if you go by evidence, that is something that we always choose first. When it comes to things like a weight loss therapy or other indications, then we choose something like liraglutide, or we may go with an agent like semaglutide. So those are the decisions that we make. And if we are now using SGLT2 inhibitors largely, like I said, for people with cardiovascular disease, kidney disease, and where we want weight reduction, and people with heart failure, I think that's a huge indication for SGLT2 inhibitors. This is how I decide for my patients.
These are very good modern medicines. The CVOT benefits of management of diabetes, which has come down, is what these drugs are all about. See, the leader study very clearly showed that when people were being treated, senior citizens, elderly people who were fully statinized, who were given enough aspirin on board, who were post coronary bypass and post transluminal angioplasty, who could be given the max cardiac care that they could be given to take care of the cardiac events. When they were given liraglutide, there was a definite improvement in the cardiac outcome mortality ratios. So that is what the CVOT effect is all about. Nobody expected an anti-diabetic to give cardiac benefits. And this was, like having a cake in your hand and eating it also. So you not only got fantastic anti-diabetic benefits, you also got cardiac mortality, which was reduced. And we all know that the leading cause of death in diabetes is a cardiac event. So we need to prevent that. And the GLP-1s are the drugs which reduce the incidence of coronary events in a diabetic. And whereas if you look at the SGLT2, which is the second good branch of medicine which take care of the CVOT benefits of a cardiac or diabetic drug, the pump versus spike theory, which was well established by the DAPA trial, which showed that the SGLT2s are the drugs which decrease the heart failure issues instead of the coronaries. So they have much more benefit in the heart failure events in a diabetic. So if you look at that angle, there are two kinds of heart failures that we are talking about. One is the heart failure with preserved ejection fraction called HFpEF, and there is heart failure with reduced ejection fraction, which is HFrEF. Patients are symptomatic when you have heart failure with reduced ejection fraction. Patients are asymptomatic when they have heart failure with preserved ejection fraction, which is generally seen in 2D echo as a diastolic dysfunction, which most of us clinicians have seriously been ignoring so far, thinking that as long as the patient is asymptomatic, we need not be very critical about it. So heart failure with diastolic dysfunction is what HFpEF is all about. And initiating SGLT2 inhibitors could make a difference in the outcome. That has been very clearly shown. And that is another cause of a MACE event or a mortality issue down the road. So SGLT2s have a different flavor. They reduce the heart failure issues, whereas GLP agonists play better on the coronaries. There are many other differences. Both are the drugs which are very good in weight reduction. In my opinion, SGLT2s reduce weight by 2.5 to 3 to 4 kilos on an average, whereas GLP agonists I found reduce weight a little more than, of course, there are cases which have reduced only 1.5 kilo. They even get to reduce weight beyond 5 kilos and 7 kilos in occasions. So in fact, they have also been approved for non-diabetics for management of obesity who are not a diabetic. Liraglutide has already given the US FDA approval for managing obesity in non-diabetics in a higher dose. So giving an GLP agonist has its own role. SGLT2 has its own role. And there are situations where I would prefer to combine both of them in a single patient, a patient can afford. And they have a much better outcome as far as the cardiac issues are concerned. I didn't touch upon the renal issue because that is another important aspect of the long-term complications of diabetes. And both the drugs have shown significant improvement in the renal outcome studies, both in GLP and SGLT2, but much more so in SGLT2. The disadvantage with SGLT2 is they are not contraindicated in renal failure, but when the creatinine clearance, eGFR falls below 30, then it doesn't have a role because, see, they have to work through the kidney. So if they're not getting excreted in the kidney, how will they work, right? They're SGLT2 inhibitors, they're glucose choline transport inhibitors. So they will not work if the renal failure is there. So you can't prescribe them. Whereas in GLP agonists, you can get prescribed them if the eGFR is below 30. So that is a place where, GLP agonists have a higher hand than SGLT2. But I think both of them have different role to play. You need to work out the metabolic, what I call as a Janam Patri of the patient, see what the metabolic horoscope of the patient is like, and then plan your therapeutic regimen accordingly.
So it is again, patient-centric. First thing is we have to, we don't need to decide based on A1C only. We have to look at the whole patient profile, right? Now, suppose first thing is what is the current recommendation? So current recommendations generally are that all people with type 2 diabetes who have, either established atherosclerotic cardiovascular disease or multiple risk factors for atherosclerotic cardiovascular disease, or have any degree of heart failure, or have established kidney disease, chronic kidney disease, then they should be on either SGLT2 inhibitors or GLP-1 receptor agonists. Now, why so? Because there are a number of studies which have shown that both these categories of molecules are beneficial in the patients who have established atherosclerotic cardiovascular disease or established CKD or heart failure. Now, in absence of these conditions, any patient where there is gross obesity, or there is risk of hypoglycemia, or weight is a concern, then these are preferred agents as add-on to metformin. Now, within the people who have, the chronic complications, as I mentioned, so people who have established atherosclerotic cardiovascular disease or multiple risk factors, first choice would be, possibly GLP-1 receptor agonist, and if not, or SGLT2 inhibitors, you can choose between the two. Somebody is not interested in injectables, cost is a concern, SGLT2 inhibitors are much cheaper. Somebody has a heart failure, SGLT2 inhibitors are a preferred drug, but if they are not tolerated, then GLP-1 receptors are a choice. Patients with established CKD or albuminuria, again, SGLT2 inhibitors are preferred drug, but if they are not tolerated well, or they are due to some contraindication, then GLP-1 receptor are in choice. Another important thing in India is the affordability. Now, GLP-1 receptor agonists are expensive molecules. If we compare to the global scenario, they are much cheaper in India as compared to other countries. But within India, they are the most expensive category of the molecules for management of diabetes, as far as I understand. And the cost is significant. Because if you are using GLP-1 receptor agonist, the monthly cost for just GLP-1 receptor agonist is almost 8,000 to 10,000 rupees a month. You have to use other agents also in addition. Now, if you look at the average per capita income in major cities is around 12 to 15,000 rupees a month. So it is not easy to afford GLP-1 RA. But SGLT2 inhibitors, and now we have generic SGLT2 inhibitors also in the Indian market. So the cost has come down significantly, and that is where they become preferred. But there are other issues with SGLT2 inhibitors. Genital infections are common. Some people who don't tolerate them well. There is significant increase in urination. Some people feel disturbed because of that. So it depends on, ultimately, it is the patient-centric choice that we have to make. And it is not just one factor that we have to consider. We have to consider multiple factors.
My next question to the panel is, with so many molecules coming in and with a lot of trials going on and with more molecules in the pipeline, does the age-old sulfonylurea still have some role in our treatment of diabetes?
Sulfonylureas have been what they call the workhorses. We've had them for a very, very long time. They are very, very effective and very, very powerful as well in terms of glucose lowering, A1C reduction. I mean, it does have its the other side is it can increase the risk of hypoglycemia. There is some risk of weight gain. So when you have these newer agents like DPP-4 inhibitors or SGLT2 inhibitors or GLP analogs, which have less of those or either no or less of those side effects, this question always comes up. Are sulfonylurea still relevant? But in our country, where cost is a very big issue, and also a lot of patients are not obese, they are thinner, and they may start out with somewhat of a lower insulin reserve, so they need a powerful kick to their for putting out that insulin. So I think whether it's even in 2022, sulfonylureas are extremely relevant for our country.
This wonderful study which has compared sulfonylurea with linagliptin has shown that so-called cardiac ischemic pre-ischemic conditioning, which was so-called lost with sulfonylureas, and the increased propensity of a coronary event with sulfonylureas does not exist. That has been very clearly shown. So sulfonylureas remain a mainstay of therapy in India, and we should consider that. May not be so popular in the Western world, but I am very much supportive of writing a sulfonylurea, especially the modern sulfonylureas like glimepiride and gliclazide. The risk of hypoglycemia and weight gain is not so much that you would find with the earlier generation. So I think we should not put all the eggs in one basket. We cannot put all the sulfonylureas in one basket and see if they all are in the same basket. We should be different, and we should consider sulfonylureas, different generations differently. We should treat them separately, and we should take it like that.
So sulfonylurea is now in a back seat. It is not the first choice of therapy. We want to use the molecule which helps us for comorbidities to get reduced, whether it is a weight reduction. We don't want our patient to go in hypoglycemia. So sulfonylurea and insulin, both these molecules are increasing the weight, and at the same time also increases the risk of hypoglycemia. But it does not mean that we don't use it. We do use sulfonylurea. Before putting the patients on insulin therapy, suppose you have a patient who is already put on DPP-4 and SGLT2 inhibitor with metformin and still sugar is not getting controlled. He is already on triple drug. Would you like to put this patient on insulin before it? If his HbA1c is not coming down less than 8, I may use the sulfonylurea. There is a definite role of sulfonylurea, increasing his insulin secretion from his pancreas, and that will help his sugar to get control. But it is the uses of sulfonylurea in such a way that it should not cause hypoglycemia. We had written a paper that a smart use of sulfonylurea helps our patient to get a good diabetes control without getting hypoglycemia. Now, with the newer sulfonylurea, particularly glycoside sustained release or glimepiride, which are very safe cardiac safety wise, at the same time, they cause less hypoglycemia and less weight gain also. So we do use in 2022 also the sulfonylurea in our clinical practice, but they are not the first choice of therapy. Before that, it is depending on the comorbidity. If you want for the weight reduction, GLP-1, SGLT2 comes before. If you want, the patient is on, he is not ready to take GLP-1, even DPP-4 is a safe drug to start with these patients. But after that, if patient sugar is not getting good control, they are very powerful anti-hyperglycemic agent, and where we use sulfonylurea in our clinical practice too.
So first thing is that diabetes, we have to understand, is a progressive disease. There is a progressive decline in beta cell function, which leads to progressive decline in the insulin levels that are produced in the body. And you reach a critical stage gradually where the insulin produced is not sufficient, even that after addition of oral agents, and person needs to give insulin. So in the initial stages, when the insulin secretion is sufficient, maybe you are able to do with 1 or 2 drugs. As the insulin secretion declines, you need to add a 3rd drug or maybe 4th drug, but usually it is recommended after 3 drugs, you should add on insulin, because possibly you have reached the stage that beta cell is sufficiently exhausted, and addition of 4th agent may not be very helpful in controlling glycemia. Since you are adding, you need to add 1 agent, 2nd agent, 3rd agent, so on. There is, if you look at the oral agents, there is no single agent which gives you a A1C reduction of 3% or 4% and can get you to target of 7 A1C or less than 7 A1C. So you need to keep on adding one after the other agent till you move on to the insulin therapy. Now, question is which one you want to add first and which one you want to add second. So sulfonylureas, again, they are very good molecules in improving glucose control. There are some drawbacks that they cause a little weight gain. There is increased risk of hypoglycemia, but they are also possibly one of the potent molecules in controlling glycemia. So they still will have a role. Maybe they will move from the first line add-on to second line add-on and third line add-on, but it is not that they are irrelevant in the treatment of diabetes. I think sulfonylureas will stay, and there are now long-term studies which have looked at, comparison with DPP-4 inhibitors and other things, and shown that sulfonylureas are also safe agents, provided you are making sure that you are, taking care of the hypoglycemia. That is the major challenge.
Our next topic is standard of care. And the first question under this session to the panel is, since there is a divided opinion amongst clinicians regarding when and how to treat hypothyroidism, what is the right level at which we should start treating it? And should we look to non-pharmacological therapies against pharmacological therapies for the treatment of the same? And at what point do we shift to pharmacological therapy if we advise lifestyle management?
So as soon as we diagnose diabetes, of course, we are going to look at the hemoglobin A1C and also how they are fasting in postprandial and how their sugars are throughout the day. So typically, if I see an A1C that's below 7, 6.5 and above is diabetes. So if I see it's below 7, I don't start pharmacotherapy. I only do lifestyle modification. Have them come back in a month with their home glucose monitoring. But in another 3 months, I look at their A1C. And if it's going in the right direction, I just keep, reinforcing lifestyle modification. If on the other hand, either the A1C has gone up or they have not responded and it's still above 7, then I would introduce an agent like metformin. But if they start out with a much higher A1C, for example, if their A1C is above 8.5, then a combination therapy is usually recommended. And even here, I use my judgment in the sense, if there is a lot of room for improvement with their diet and physical activity, prescribe that, add metformin, look at their home glucose monitoring and, reevaluate them in a month. If things are all going extremely well, I keep following that till I see the next A1C. But on the other hand, if they already come in with a very high A1C, more than 9, 10, which many of our patients in India do, we may have to start with a combination therapy, either a DPP-4 plus metformin or SGLT2 plus metformin or SU plus metformin, depending on all these other factors that we talked about.
See, if we look at the management of type 2 diabetes patients, I would say there are 4 cornerstones of therapy. One is the lifestyle intervention, what you can, typically term under non-pharmacological therapy. Second is the pharmacotherapy, which includes obviously all the, oral agents as well as insulin or other injectable agents. Third is the regular monitoring. And fourth is so lifestyle, pharmacotherapy, and monitoring. These are the key components. And okay, I think we'll come to fourth also. Maybe I've covered in lifestyle interventions 2 things, which is diet and exercise. Both are very, important things. So currently, earlier the concept was that if you have a new detected type 2 diabetes person, the first step would be lifestyle interventions, which include a change in the dietary behavior or, diet which is more conducive to good glycemic control or control of glucose levels, and increase in physical activity, which improves the disease status. And we start with the lifestyle interventions, wait for at least 3 months, and if we are not able to achieve glucose targets, then we start with the pharmacotherapy or oral agents or insulin, whatever is the indication. But now most of the guidelines currently agree that we should start early with the treatment, and most guidelines say that most of the people with type 2 diabetes, at the time of diagnosis, we should start with both lifestyle interventions and at least one drug, which is metformin, and that is recommendation for most of the people. Now there are some guidelines which also look at the A1C level, which gives a estimation of the last 3 months of glucose concentrations in blood, and the normal range we know is less than 6.5. So anybody who has A1C more than 7.5, the recommendation is that maybe you can start with 2 drugs in addition to lifestyle interventions. And there are other guidelines which would say that, okay, you should start with 2 drugs and lifestyle interventions if the A1C is more than 9.5%. But in general, the trend or the evidence is that we should start early in the course of disease, and we should be more aggressive in controlling glycemia. So almost all patients, we should start parallelly on lifestyle interventions, which basically takes care of dietary interventions as well as increased physical activity. In addition, we start with metformin or metformin plus one more drug for most of the patients, depending on the patient profile.
See, I work with a team of healthcare providers, which consists of dietitians, health educators, not a psychiatrist, but a counselor, and a moral booster. We work together for the better outcome and management of diabetes. But I believe in the guidelines. Do you know there are more than 47 guidelines in the world today?
Yeah.
Telling us diabetes. And the first thing that every guideline talks about and everything, and there is enough data to show that is lifestyle management. LSM is something that we focus a lot upon. It is unfortunately the belief of the media and the common man that doctors are here only to prescribe medicines, which is not true. The leading doctors always insist on a better lifestyle management, which is obviously non-pharmacological. And if you focus a good amount of lifestyle management and you do it in a scientific manner, in a detailed manner, and in a positive manner, we have seen fantastic results coming. Of course, that does not mean that pharmacology is not required at all. It's like, you're going to the sea, you have to go to the sea, you have to face the storm, but you also need maps and guides. So you cannot travel on the sea without maps and guides, and you cannot just sit on the map and feel that I've been to Honolulu or I've been to Hawaii and I've come back. So both are required. It's a synergistic approach, both are required, but the role that each branch has to play in the management of diabetes has to be laid down very nicely, and it has to be tailored as per the patient's metabolic parameters, the patient's lifestyle. What's important about lifestyle management is it cannot be done in a day's time. It cannot be enforced over 1 month or 2 months. It takes years to do it. And like the word it suggests, it's lifestyle management. You have to change the thinking of the patient. You have to change the approach of the patient towards managing his lifestyle. And unless he or she is comfortable and is a willing partner to change the lifestyle, this aspect of therapy doesn't work. Whereas pharmacotherapy can work because you just take the medicines. But lifestyle management gives wonderful results if it is done with the consent of the patient and with the patient's heart into it, So you have to understand the patient's psyche. The patient has to understand the relevance of this and has to be a willing partner. And then we've seen very good results. In fact, if you see this year's poster presentation of ADA 2022, with Fitterfry, we have published the data where we have shown that good amount of lifestyle management and exercise therapy has been successful in getting the HbA1c down by 1.5 to 2 grams. With good lifestyle management alone without increasing the burden of the prescription. And we have managed to reduce the weight, and we have seen a lot of quality of life coming in the patient. So it is not a difficult thing to so-called, I will not say absolutely, so-called reversal of diabetes. I'm not saying diabetes can be totally reversed, but simple thing, I mean, think about it, friends, that if you can get your HbA1c down by 1.5, if you can reduce some medicines by 50%, and you can give a better quality of life to your patients by lifestyle management, then why not? And here it should be done by qualified people. You need to have qualified dietitians and physiotherapists and qualified diabetologists on board. The common mannerism is that you go to a gym, you pay a hefty amount of money, start pumping up your muscles and develop abs. That is not equal to lifestyle management. I feel whether you go to a gym or you go to a physiotherapy center, wherever you are comfortable, you need to work under supervised and trained people and not untrained people. And recently we have seen the deaths of so many people occurring who have been very aggressive in their gym workout. Many celebrities have paid with their lives. So that should be a lesson. The target should not be to reach the heavenly abode of reversal of diabetes within a month or 2 months. Itna bhi josh, jaruri nahi hai. Josh hona chahiye, but it should be tailored and it should be done in a scientific manner. It should be done with scientific temper.
So the non-pharmacological therapy means lifestyle modification, and that therapy continues from the diagnosis, from the persons who are at the risk of developing diabetes, who are pre-diabetes or diabetes. So the lifestyle modification or non-pharmacological therapy starts from day one. And that is always, whenever patient comes, we always talk about that non-pharmacological therapy, and we want to promote that. We want to educate the patient that please go for a lifestyle modification. If you will not able to control your diet, if you will not be able to do your good exercise control, it is not only the sugar control which is important. This lifestyle modification itself is not only helping us for a good control of diabetes, but also prevents the complication too. Now, a person with the HbA1c, which is like in a pre-diabetes stage, where we can give the first therapy is a lifestyle modification, non-pharmacological therapy. Even after giving them a non-pharmacological therapy, which is lifestyle modification, person's sugar is not getting reduced or HbA1c now going more. Suppose we started him on 6.2 and now he has reached to 6.4 or 6.8. Definitely now he needs pharmacological therapy. We start with first line, which is metformin. It's a choice of drug as an insulin sensitizer. And then depending on the comorbidity, we add the second drug, So that is what pharmacological therapy is started. But that does not mean you have started the patient on a pharmacological therapy. Still, we continue to talk about non-pharmacological therapy, that is lifestyle modification.
As it stands, we have multiple pharmacotherapy options when it comes to diabetes, and as it stands, we have multiple non-insulin pharmacological therapies when it comes to the treatment of diabetes. So at what point do we decide to shift to insulin, and what is the right way and the right time to prescribe it?
So a lot of our patients actually need insulin, at least some amount, what we call some basal insulin, because they are deficient, insufficient in insulin, not completely deficient, but there is some amount of insulin insufficiency. So if I see that either they are starting out with a very high A1C, or if they're losing a lot of weight, or if they have other, intercurrent, or simultaneously, if they are unwell, they have things like TB or HIV and conditions like that, I right away start insulin. But otherwise, like I said, we want to get to that A1C quickly. We don't want to, keep delaying that process. So after giving the patient a trial of OHAs for maybe a good 6 months, if you don't see the, things moving in the, reaching the target, or at least moving well in the right direction, I think we should have the conversation with the patient about basal insulin, explaining to them about how it will quickly bring them to their goal range, their quality of life will improve, all of those things, and prevent complications. Most patients are acceptable to them.
So if you go through we practice evidence-based medicine. So we go through the various algorithms which have been laid down, and guidelines are meant to guide us. They're not meant to be followed blindly, but then they are a essence in some. The position statement and guidelines is a collective effort of the stalwarts of diabetologists across the world over so many years. Their experience speaks and they tell us a lot of things. So definitely we are guided by these guidelines. And if you go through the guidelines till 2021, American Diabetic Association and the ACE guideline, Association of Clinical Endocrinologists of America, these people have given the guidelines where they would be recommending starting with sulfonylureas. I mean, the first drug in pharmacology is always and always metformin, unless there is a contraindication. Sulfonylureas and oral drugs. And like the previous guidelines was, if the landing HbA1c is more than 9, or if things are not under control, then you initiate insulin. So that was generally the recommendations. Or if people are not comfortable with more than 3 drugs on board oral, and there is enough data to show that if 3 drugs are not able to get your HbA1c on board, adding a 4th and a 5th oral is not going to increase the outcome. It's going to add to the burden of complications and side effects. So insulin could be considered. But the people who are propagate, say there are 2 schools of thought. People who propagate insulin. Other people who say that in type 2 diabetes, where there is a lot of insulin resistance, because the pancreas has to outpour a lot more insulin to take care of the insulin resistance. And in the bargain, your pancreas gets burnt out over a period of years, and it gets converted to type 1 diabetes down the road. So early initiation of insulin can give rest to the pancreas, and it can prolong the life of pancreas. Those are the people who recommend starting insulin early on the therapy. And as per the guidelines, insulin could be initiated later on in the therapy. So there's not clear consensus about it. If you ask me, I like to go for a multi-pronged approach. And I feel insulin is a part of the regimen. It should be initiated. And there is enough data to show that it is not the patient who's scared of insulin. It is we physicians who are most scared of insulin. There is more inertia on behalf of the physician to prescribe insulin when it is required. And I think that inertia should be removed, and people should be initiated on insulin early. Another, I prefer to start insulin. I'm not against insulin. Let me be clear on that. And I feel when you have good second generation basal insulins available, which are sort of like true basal insulins, they actually last for 24 hours. There is no shoulder, there is no peak effect. There is not hypoglycemia, rebound hyperglycemia, etc. with these second generation basal insulin. The benefits are comparable to the previous insulin, and the hypoglycemic episodes are much less with second generation basal insulins. So why should not we start second generation basal insulin as an initiator insulin? And why don't we intensify it with the prandial insulins when required? So these are the issues which are required, and they should be initiated. And I think insulin should be taken on board as soon as we can and we need. What's important is we should be aggressive with our therapy. The UK PDA study has clearly shown what is known as the metabolic memory effect or the legacy effect, that if you like to get your HbA1c down, when the landing HbA1c was 8, you get it down to 7.5, 7, 6.5 over 3 to 4 years, and then you find that the drug is not working, you increase the dose of the drug, and you find the drug is not working, then you add another drug, then you add a third drug, then you add a fourth drug. Down the road, what happens is after 10 years, you realize that the HbA1c can never be brought down to 6 to 6.5 or 7. It becomes difficult to get it down below 8. So what is required is you have to be intensive and aggressive in your approach. You need to start multi-drug therapy, non-pharmacological therapy, lifestyle management. You need to be aggressive, because what kind of metabolic memory you stamp on the pancreas early on is what will remain later on. So the earlier and the aggressive approach you have, you get a better outcome after 6 to 7 years, which is what we are looking at. Because after 7 to 8 years, you start developing nephropathies, cardiomyopathies, coronary effects, heart failures, and other complications of diabetes. So if we want to avoid that, we have to be aggressive right from day one.
So insulin therapy, early initiation of insulin therapy versus the right time of initiation of insulin therapy, that is very important thing. Now we talk of early because most of our Indian patients are actually delayed for insulin therapy. Insulin therapy should be given a person with type 1 diabetes, definitely in perioperative, in hospital management, or whenever there is a anabolic status where patient is in catabolic status, where patient is losing the weight and all symptoms of hyperglycemia, insulin is to be given. Insulin is to be also given when a person is already on triple or quadruple therapy, where already sulfonylurea is being used. He is already on 3 or 4 drugs of oral anti-diabetic agent, but still sugar is not getting control. Probably that is also the right time when person should be started with insulin. Now, which insulin? That's again important. If fasting hyperglycemia, if that sugar is not getting controlled, remaining more than 150, I think that's the right time we should start with basal insulin. But many of our patients who have fasting as well as post-meal, both are very high. First, you try to fix the fasting control. That is, try to get fasting around 100 by giving them a longer-acting basal insulin. That is the right time. And then you monitor patients, self-monitoring of blood glucose. Try to decrease the carb content of the diet and try to achieve the post-meal glucose level less than 180. My target is fasting around 110 and post-meal 180 below. And then mostly these patients will achieve the HbA1c of around 7. But if they don't achieve, then probably they may require a meal or a bolus insulin injection. That's what we start with basal plus or basal bolus therapy for our type 2 diabetic patients. But in average, the clinical inertia of a physician as well as from the patient side, there are many patient factors also which are responsible for delaying this insulin therapy. They don't want to take injection. They always want to have some excuse that they will start it a little later. Let me try our level based with the lifestyle modification, with the therapy, with the medication, increase it. And in India, we have seen many of our patients who are on not only on quadruple therapy, rather more than 4 oral anti-diabetic agents are going on, and still they are not achieving good glycemic control. So that should not happen. And that is what delayed insulin therapy. So we should use insulin at the right time when 3 or 4 drugs are not achieving good glycemic control. That is the right time to start the patients on insulin therapy.
See, it depends on patient profile. So first thing is, any patient who's coming with severe hyperglycemia. Severe hyperglycemia is generally defined as the blood glucose level of more than 250 milligrams in the fasting and more than 300 or so in the post-meal state, and A1C level going above 9.5 to 10%. And another important thing is patient has symptoms suggestive of insulin deficiency, that there is increased thirst, there is increased, urination, there is weight loss, all features of catabolic state. Then it is always better to start with insulin. And this is an indication for starting insulin as first-line therapy in people with type 2 diabetes. Otherwise, people with type 2 diabetes who are on oral agents and are not able to achieve good glycemic control, even after you add on addition of 3 agents in addition to lifestyle interventions, becomes an indication for initiating insulin therapy. Also, people who are well controlled on oral agents and lifestyle interventions. If they have any kind of emergency, there is an accident, there is trauma, there is any surgery, there is myocardial infarction, ICU hospitalization, some severe infection. So all these are also situations where you would prefer to keep the patients on insulin for a transient period, and once the patient is normal, then you go back to the oral agents.
We move on to our next topic, which is based around preventing complications of diabetes and other endocrinopathies. So my first question in that respect is about gluten and celiac diseases. Have you, in your clinical practice, seen any level of association between Hashimoto's and gluten insensitivity and celiac diseases? And if yes, then what is your approach towards it?
Hashimoto's and gluten insensitivity both are like generally sort of autoimmune diseases. Diabetes is also a role where immune function is impaired. Now, there's a lot of talk about microbiota playing an important role in both of them. And there is a lot of role about stress and lifestyle management. We see cases which have got both sometimes occurring together if you screen for them. Sometimes they're present in sporadic, isolated episodes. And sometimes they're difficult to pick up in the early stages. It's not very easy to pick them up. And you also see them sometimes having an overlay of diabetes. So this is something, like there is not a lot of data available now. I think it's yet in its infancy. We do not have much sound understanding about it right now, just as NASH and NAFLD is coming up as a big thing in diabetes management today. It's one of the major areas of study, and it is getting a lot of importance today, which it was not getting 5 years back. So I think these things are important and they should be screened off in every diabetes. Just as you check for sugars, you check for uric acid, you check for vitamin D, you check for microalbuminuria. These are things which should be screened clinically, at least, if not metabolically initially. And if they're present, they have to be given their proper attention and therapy. And that would help in the management of diabetes down the road, because I feel immune system plays a very important role. And not only a bad lifestyle, but stress has played a very major role in getting these autoimmune diseases like SLE also and Hashimoto's also and diabetes in a big way today. If you look at the figures in the Western world, the number of diabetics have reduced definitely, but the number of diabetics have increased in the younger population everywhere, and much more so in India and the Asiatic countries. And the reason is today's younger population is gripping a lot with a high level of stress management than they were doing with their predecessors and their forefathers 20 years back. So stress plays a very important role, and it comes out on your body in various diseases, especially such of these diseases. So there is a definitely correlation here, and they should be checked for and they should be treated as appropriately.
There is a lot of observational, relationship in this, and which is why we do see patients with presenting with many of the autoimmune disorders and celiac disease.
My next question regarding the complications to the panel would be, how is the age at the time of diagnosis of diabetes associated with different complications or different adverse outcomes?
I'm not going to talk about cardiovascular and renal outcome, which obviously increase as age goes by, which we are all aware of, and there's enough work and enough talks on that, so I won't discuss that. But what I would focus today on this is, of course, there are too many adverse outcomes as age of diabetes goes by. Just as you have a true biological age, and you have a chronological age. If you do the Framingham study, if you do the Framingham score, you realize that you might be 60 years old, but your heart might be 80 years of age, or you might be 30 years of age chronologically by your birth on this planet, but your heart might be 60 years old, So similarly, a person may be 40 years of age, but his diabetes may be 60 years of age, It's difficult to pick up diabetes when it strikes. It's a silent disease. Many people get picked up by health checks or by some other complication by which they come to a doctor, like unhealing wounds or cancer or maybe a coronary event or a stroke. They don't come to you primarily with a diagnosis of diabetes in their hands. So diabetes has been there in the body for a long time, and we know that till the pancreatic function, the beta cells of isolates of Langer, and still the reduction is more than 50%, you don't develop clinical diabetes. So there's a big honeymoon period, there's a big pre-diabetic period remaining, which is equally important as diabetes, which is not screened for many times. So the longer you have metabolic dysfunction by diabetes in your body, the earlier you will develop complication. So nephropathy, cardiac events, retinal events will all develop down the road. But what I would focus on, since you asked me this question, is glycemic variability in hypoglycemia, which is not something that many of us focus on, primarily because hypoglycemia is something which many patients don't report. So as your age advances, the symptoms of hypoglycemia get retarded. As more autonomic dysfunction sets in, people develop hypoglycemia, but they may not have symptoms of hypoglycemia. So very few people present with symptoms of hypoglycemia. And this hypoglycemia goes on and on in the body, causing a lot of coronary events and stroke events. And people they don't realize that they've suffered with chronic hypoglycemia for a long time. So unless you do a CGM or a structured SMBG, self-monitoring of blood glucose, unless it is done in a structured manner, not blind SMBG, people do their sugars at any time. No, not that way. A protocol has to be laid down that I will do 3 times a week, only for the pre-sugars, before meal sugars. I will do 3 times a week, only the post-sugars, post-breakfast, post-dinner. Twice or thrice I'll check for presence of dawn phenomenon, somogy. I'll do it at 3 o'clock in the morning. So unless you do a structured SMBG and you link up those values, so there are glucometers available today with wonderful apps on your smartphone, which are linked through Bluetooth, where you can collect your glucose values and they give you a structured SMBG graph, very similar to what you get when you do a CGM. And you can make out how much hypoglycemia the patient was sitting in, how long was hypoglycemia, what caused hypoglycemia. You can correlate it with the quality of meal, the type of meal, when you taken the meal, how much you exercise. And that insightful information makes a lot of difference in managing the patient by changing his prescription or changing the lifestyle. So that is something that I would talk about. As the age advances, the hypoglycemias increase, the duration of hypoglycemia increase. And the fourth dimension of diabetes pathophysiology, which we call as the glycemic variability, is something which nobody picks up, because doing a fasting and post-lunch and an HbA1c is definitely not the way to go. You cannot actually pick up glycemic variability by doing an HbA1c. An HbA1c tells you only an average over 2.5 to 3 months. And you get different kind of labs of HbA1c, from different leading labs, different values come, though they use a gas chromatography method. And there are so many conditions where a HbA1c is not a reliable test with abnormal hemoglobins. Many other conditions, I won't go into that. There are many conditions you don't get a reliable HbA1c. So HbA1c is, though it's the standard of care today, it's getting sort of a myth. It's not really something which gives you a lot of information. Today, what we look at is called as TIR, time in range. So if you do a CGM, what the TIR Academy says is that if your range, they accept as 80 to 180, if the glycemia is between 80 to 180, at least 70% of the time in 24 hours, then the risk of complications is much reduced. And if your TIR gets below 70%, then the risk of retinopathy, nephropathy, cardiomyopathy increases by as much as 10%. So TIR is the way to go in the future. And if you can keep a person's sugar within range, at least 70% of the time, the adverse events reduce. So to answer your question, down the road, one should be more careful about glycemic variability, should be more careful about hypoglycemia, especially asymptomatic hypoglycemia. One should start picking up reduction of EGFR. Should not wait for creatinine to rise up, because by the time the creatinine rises, renal failure is set in a big way. So checking for microRL, checking for EGFR, checking for early evidences of retinopathy by doing a retinal scan or a retinal photo shoot rather than go for a detailed retinal exam. This is something which can be done on outpatient basis also. Other ways to go for picking up adverse outcomes of diabetes and catch them, nip them in the bud when they are there before they develop into full-blown fatalities.
So the simple answer is, the younger you are, you have a longer duration that you are going to be around. So a greater chance for complications to develop. That's number one. Number two is, of course, a young person, very young person, lifestyle modifications and being on a diet and following physical activity and all of those things can be a challenge for them. So being engaged in their diabetes becomes an issue. If it's a woman, of course, the younger you are, you may be in your reproductive years, and therefore the risk of this becomes pre-gestational diabetes, and the challenges along with taking care of the pre-gestational diabetes, planning a pregnancy, adds another layer of difficulty to their diabetes. But the main thing is, the younger you are, the greater the risk of developing complications of diabetes because of the number of years of diabetes one would have, and that's a well-established risk factor for complications.
And my last question in this regard would be, how is the psychological resilience associated with better physical function and quality of life in patients with type 2 diabetes?
See, type 2 diabetes management is in a completely a patient's self-education. And a psychological part plays very important role. Sometimes you educate the patient so much, but still patient is not following all the measures of getting control. So lifestyle modification, it completely depends on behavioral changes, behavior therapy. Patient is not ready to accept the diet, is not ready to accept the regular exercise, is not doing it, not doing any aerobic, not muscle strengthening exercise. So psychological factors are very, very important. Other than that, a mental stress also increases the glucose level in persons with diabetes. And that is also responsible for their uncontrolled sugar too. So psychological aspect of a person with diabetes is very, very important. Sometimes they need psychotherapist and even psychiatric intervention also for a better control of diabetes. Because self-management of a diabetes can be improved if person's psychological aspect can be taken care. Otherwise, he will not able to take care of his diabetes. He will not monitor it regularly, and he will not uptitrate the therapy, and he will not do regular physical activity as well as diet control also, and that is responsible for his uncontrolled diabetes. So diabetes and mental stress is very closely linked, and we should take care. While talking to a patient, we can understand that if patient is depressed, psychologically he is not stable, or he does not want to change his lifestyle, or his behavior therapy requires some psychological intervention, we must take the help of expert for his better care of diabetes.
This is a very, very important question, because mental health and diabetes control, and also some complications like heart disease, there is a what we call a bidirectional relationship. If your mental health is poor in terms of depression or diabetes distress or coping mechanisms and all that, then that worsens your diabetes control. And when the diabetes control gets worse, the quality of life gets affected. People sleep poorly, they may have aches and pains, they may feel tired, they may not have motivation. So that further, makes the glucose control poor, and this vicious, cycle goes on. Very, very close relationship between the two. And the resilience is a very important word that you brought up. And I just heard a fantastic talk by the president of the American Heart Association, who said, we are not born with a resiliency gene. It comes from relationships and family support and all of those things. So that again underscores the importance of the support system that people with diabetes need.
With increasing consumption of processed foods, there is an increased consumption of preservatives and unwanted dietary elements. What is the contribution of these to obesity as well as type 2 diabetes?
Type 2 diabetic patients, the diet is a major challenge. In our clinic, we have dedicated nutritionists for type 1, for type 2, explaining them about the carb content, explaining about the different diet. And we explain the patients that they should take more of fibers, more of fruits, vegetables, salads, dal, more pulses, less carbs, complex carbohydrate, buttermilk, nuts, they are more helpful. But patients who are taking, some of them are using the diet which contains a lot of fat, and that is also with preservatives, using frozen food which contains also a lot of fat, and even the carbs also very high, and that is not good. So we try to explain the patient that what is ideal diet, what is healthy diet, not only for the persons with diabetes, but for everyone. How a diet can help for weight reduction, how it can help for your weight maintenance, and how it can help you for a better control of sugar. This diet, healthy diet, which is explained to the patient, is actually for everyone in the family. It is not only for the who is obese or who is diabetes. It is for everyone in the family. A healthy diet which contains typically only 25% of your plate size should not be more than carbs. And then definitely carbohydrate, more than 50% of your plate should not be more than carb. And then there should be a protein, there should be a good amount of fiber and fat also in the plate. That is what ideal healthy plate diet, which we explain to our patients.
First thing is dietary components directly. If you look at causation of diabetes, there are some studies which have shown that increased sugar intake is related to increased risk of developing type 2 diabetes. In general, all calorie dense foods are prone to, induce or, lead to development of obesity. Now, it depends on how much one eats. People who are taking calorie dense foods but making sure that they are exercising regularly, their overall intake on day-to-day basis or week-to-week basis is not significantly, grossly disturbed, then they will possibly not gain weight and they will not have much effect on diabetes. But people who are, and the same people, if they are very irregular with eating pattern, if they are diabetic, their control will be haywire. Now, obesity, if we come to, is a key driver for development of diabetes. Almost 70 to 80% people with type 2 diabetes are either overweight or obese. So, obesity is one of the major drivers for development of type 2 diabetes. Now, obesity comes from where? It comes from imbalance in the caloric intake and the caloric expenditure. This happens on the background of genetic predisposition and multiple environmental factors like decreased physical activity, increased physical inactivity, the binge eating, the pleasurable eating, the calorie-dense foods, and so on, and stress factors. So there are multiple factors which influence this. Coming to the question of preservatives, as for the preservatives, these, some of the chemicals which are used as preservatives are being seen as endocrine disruptors, lead to some epigenetic changes which lead to development of, can lead to development of insulin resistance and beta cell dysfunction. But there is no concrete evidence as of now to have, to suggest a strong link between the food preservation and development of diabetes or obesity.
So it's well established that obesity is a big risk factor for diabetes. Again, someone very well known says that, Dr. Philip Holmes says that it's not the obesity that causes the diabetes, but what causes the obesity causes the diabetes, meaning overeating and underactivity and sleeping less and stress and all of that. Be that as it may, we still know that as BMI goes up, the risk of type 2 diabetes goes up exponentially. And the role of, any of these, what we call endocrine disruptors and environmental disruptors and all of these things, whether it is preservatives, whether it is foods that are like sugar substitutes, so many of them have been linked with, the metabolic changes, metabolic syndrome, type 2 diabetes. So I think the simple answer is foods have to be as, natural, and I'm not saying organic, but as natural and no preservatives, home cooked, preferably, homegrown, and simple foods like our traditional foods, which our forefathers have been eating, I think is the best formula for all of us.
Next topic for this summit is food-based dietary guidelines. I'm sure most of you must have gone through a lot of studies regarding the role of vitamin D in protection against cancer and autoimmune diseases, including diabetes. Very recently, we went from the omnious octet to a dirty dozen around the pathogenesis of diabetes, where vitamin D took center stage. Now, what is the scientific evidence to back this? And also, what is your view on this?
I think it is yet in its infancy. Vitamin D does play a role. Vitamin D is a very useful drug, but it's not got a level 1A kind of a credence right now. It's not a drug which would be a main drug. If it was, it would have come in the position statements and the guidelines by now. It would have sat next to a sulfonylurea or a GLP agonist today, which it doesn't occupy. It is not. It is a good addendum. I would not think of putting vitamin D in each and every prescription of my patient just because it's like, I mean, I'm not comparing in the right place of, pardon me, but giving transplants to replace a microbiota, or giving microbiota prescriptions in every prescription of diabetes. These are like some good drugs, like we used to have prometazolone in every cardiac patient in the past. These are some good add-on drugs. I may be wrong, but I feel today vitamin D is probably needed when there is severe hypovitaminosis D. And I would encourage my patients to take their share of vitamin D by sitting in the sunlight rather than a prescription as a mandatory prescription in every patient. I don't think the evidence is out there telling us that a heavy dose of vitamin D is required for every diabetic. I don't think so that is the case today. Maybe down the road, but not today. So, but then I would encourage people to take vitamin D when they are deficient. I would encourage them to take their natural sources of vitamin D by spending more time in the sunlight and doing more of physical exercises rather than pop a pill, every day and get the vitamin D.
My short answer is there's a lot of observational data, but there is not hard data to say. There's observational data linking vitamin D deficiency, or people with these conditions may have vitamin D deficiency. Vitamin D deficiency is so common, so finding that link may not be difficult. There's also a lot of observational data finding the connection between the two. But what we don't have is just normalizing the vitamin D or supplementing vitamin D lower the risk of these things. We don't have that. So common sense says that vitamin D is so important for health, for skeletal health and non-skeletal health as well, and that we should optimize it. How do we optimize it? Because there is very limited. I mean, when you're a vegetarian, there is zero dietary source of vitamin D, and if you're a non-vegetarian, fish and egg yolks, and so even that, especially in our country, people don't eat that much of it. So food sources actually are limited. Milk is not fortified in our country with vitamin D. So sunshine is our only source. And the sun can be quite oppressive in our country. And people have all other, socio-cultural things about tanning and, pigmentation. And some people get headaches. And also currently the way we live, with glass everywhere and we work indoors, we don't get that much of sunlight, and we need to get it between 10 a.m. and 4 p.m. And that's the time most people are working. So you can see how difficult this can be. So we'll have to find a public health solution, which is food fortification. Or when we identify vitamin D deficiency, we recommend supplementation.
We move on to our next topic for the summit, of physical activity. My first question under this, how does physical activity alter insulin sensitivity and pancreatic beta cell function in diabetic patients?
So, increased physical activity is an important component of good health. Regular physical activity is must for everyone. Everyone means everyone across all age groups. If you are physically inactive, actually increased physical inactivity is being seen as one of the important factors which is leading to development of all kinds of non-communicable diseases like obesity, diabetes, high blood pressure, dyslipidemia, and even some cancers. So physical inactivity is a major challenge, and we should cut down physical inactivity and improve physical activity. Now, when we have regular physical activity, it leads to increase in aerobic respiration. It improves the mitochondrial function. It improves muscle activity. It leads to depletion of fat from the muscle. It improves storage of adipose tissue in the fat also in the adipose tissue. It reduces the turnover of free fatty acids from fat tissue, decreases insulin resistance. If you have significant physical activity and you are balancing it with the caloric intake, if you are able to lose weight, then this leads to depletion of lipid content in pancreas. The ectopic fat deposition that is there in pancreas in type 2 diabetes, if you have significant caloric deficit. Now, how do you create caloric deficit? By increasing physical activity, by decreasing the caloric intake. Then it is helpful in decreasing the pancreatic lipid content and improving the beta cell function. And in fact, there are studies which have shown that if you give very low calorie diets, then you can actually decongest pancreas from the lipids and improve beta cell function to the extent that you can cause remission of diabetes. So health and exercise is not only improving this, it is improving metabolic state in general. It improves your cardiorespiratory fitness. It improves your vagal tone. It improves your mental health. It is one of the antidepressants, strongest antidepressants that you would, find. It has very strong positive impact on mental health. So exercise is something which is good for everybody. And the studies have shown that even in elderly, even taking into account of risk of, injuries and falls, there is net benefit of exercise at all ages as compared to the risk with exercise.
So physical activity is very, very important. Now, what are the physical activity which one should do? One is aerobic, which is walking, swimming, cycling, all this exercise. Even running is also very good. The second is the muscle strengthening. That improves the insulin sensitivity. And that is what most of us are not doing. We do walk, we do run, we do cycle, we do swim, but we don't do muscle strengthening exercise, which is important for increasing insulin sensitivity. The third important exercise is stretching and abs, particularly only the exercise which helps us for abdominal abs, because we have a lot of visceral fat, and that require yoga, that requires stretching, that require abs, that requires floor exercise. And last and very important is respiratory exercise, meditation. So ideally, a person should have a combination of all 4 and 5 different type of exercise, and one should do for almost 80 to 90 minutes. If 30 minutes daily walk is sufficient, that is aerobic exercise, remaining time 15-20 minutes of a abdomen exercise, stretching, yoga, maybe on alternate day. Other alternate day persons can do the muscle strengthening exercise. That is what is recommended. That helps to increase the insulin sensitivity, improves the pancreatic beta cell function, improves the glucose control. If we use only aerobic activity, it is insufficient exercise. Now, other than that, a person should be also more physically active throughout the daytime. Prolonged sitting is also equivalent of smoking. So like it's a big risk factor for someone to develop coronary artery disease. So that also we explain the persons to have a regularly increasing physical activity and throughout the day more physically active. More than 90 minutes, one should not remain in sitting position. He should stand up and do even for 1 or 2 minutes or 5 minutes some physical activity. So increasing physical activity definitely improves. That is what we call is non-exercise induced thermogenesis also. That NEAT is also responsible for some amount of your calorie consumption, and that helps also for weight management. So this is how we explain the patient, and we ask them for a regular physical activity. Rather, I always make a exercise should be prescribed. The way we are prescribing the nutrition, the way we are prescribing the diet chart of the day, similarly we should also prescribe the physical activity for a person's on our prescription paper.
Great question. Physical activity absolutely increases in lowers insulin resistance or improves insulin sensitivity in so many ways through the muscle, and then it changes it could impact on the weight, and therefore the insulin resistance comes down. sense of well-being. And usually people who are, physically active, you expend calories, and therefore glucose control improving. And when the sugar comes down, there's also this kind of a relationship between glucose and insulin secretion, right? So if you have very high blood sugars, that itself is what we call glucotoxicity, makes the insulin production go down. So if you normalize the glucose, obviously the insulin production also improves. So in every way, so many ways, mental health, physical health, cardiovascular fitness, in every way, physical activity is good for a person with diabetes.
Now let's move on to focusing about the rehab requirements for old age patients with diabetic complications. How do we improve the health of the population while being patient-centered or personalized in our approach, since the past 2 decades have emphasized that a one single fits all approach cannot be applied to a population?
I think the best way, Dr. Amol, to improve the outcomes in the geriatric population and in the population overall as a whole is to impart health education. And what better way to impart health education than to do it from the sources, from the authorized sources. So you're playing a very important role. Docplexes is something I respect and regard because you're exposing yourself to the general population, not only medical people who are getting information. Now you have a panel of stalwarts like Makar sir and Bansi sir and Usha ma'am who would be talking very soon. And these are the stalwarts who would be giving authentic information to the lay population. What I realize is most of my patients who come to me are all Google hungry. They pick up information from Google or WhatsApp University, as we fondly call it. So anybody can write on WhatsApp, anybody can write on Google, and what they feel, what their heart likes is what they pick up, and then they try to teach their doctor as to what the way forward is, in life. So what's important is picking up authentic information. I tell my patients that if you put X amount of money in the bank and you're scared you'll get a call from the income tax authorities, is it true? It's not true, because they have a set of laws and they are the authorities. What you learn from your colleague on WhatsApp or from your society member or your neighbor is not the way you decide how you invest money, which is a very important part of your life, isn't it? So you go to a qualified investment planner, or you go to some qualified sources who tell you how to invest. Otherwise, you lose a lot of money. So why don't you invest in your health through qualified people? Why do you invest on your health from unqualified sources? So there is a plethora of unqualified bulk of information on the net, which misguide a lot of patients about how to manage lifestyle. There's a lot of money there, which is collected by a lot of non-qualified sources. And people end up in complications and come to us later on in their life with a lot of complications of diabetes because they have followed X lifestyle, which was a misguided lifestyle. So come to authorized sources. There is a plethora of information done by various bodies like you, Docplexes, American Diabetic Association, WebMD. There are a lot of resources. A lot of doctors are running their own parallel online presence where they're educating authentic information to the population as a whole, and they're doing a human service to mankind by giving very simplified version of complicated medical knowledge in a palatable format that you can follow. And you can do a wonderful job by following that. I mean, nobody said you can't eat sweets. Nobody said you can't eat fruits. It's a misconception that people have that they just stop touching sweets and fruits and sugar in their tea totally and completely, which is not the way to go. I mean, how can you live your life like that? So, but that doesn't mean that you can start eating cakes and fast food whenever you want, or cold drinks whenever you want and as much as you. So it's not either way. You have to understand how to take, what to take, when to take, and how much to exercise, what to exercise, how to exercise. So lifestyle management and looking for complications for diabetes, sticking to your doctor plan of therapy and being regular with your doctor. Many patients are not regular with their doctor. They come to their doctors only when they have complications, and they change prescriptions or they take polytherapy. They take treatment from 4 doctors at the same time, resulting in more complications than benefits. It's like I call them, you cannot run 2 antiviruses or 2 anti-malwares on your computer, right? You have 3 leading antivirus providers. You can't install all 3 of them just because you can afford them. Will cause more complications. You have to trust one antivirus and stick to that. So to trust one good diabetologist and stick to his therapy rather than take therapy from 4 different doctors for the same thing. So these are the issues which you see in the long run. I think the most important thing to prevent complications in the population as a whole is to be aware, to have good knowledge, but to have the right knowledge from the right people. So start attending good online resources or fix up appointments with your doctors who are very happy to sit down and coach you and teach you. Learn from them, learn authentically, and remove a lot of complications. In diabetes, many complications are avoidable. Hypoglycemia is an avoidable complication. Heart failure can be prevented in a big way. Renal dysfunction can be prevented in a big way. Picking up complications early on in the disease and taking therapy early on can prevent triple artery bypass in the future, can prevent a laser ablation of your retina in the future, can prevent amputations, can prevent gangrene. You know? So many things can be taken care of. Foot care, hand care, nail care, eye care. There are so many cares in diabetes which your doctors are focused upon that as patients we are not focused upon because we are not educated about it. We take a lofty approach to management of diabetes with costly apps that we buy, but we don't clean our nails. We don't clean our genitals. We get urinary infections frequently, especially if you're on an SGLT2 inhibitor, which can cause a lot of urinary infection if you don't clean your genitals. So these are a lot of adverse events which occur during the life of a diabetic if you're not careful. Checking for loss of hair in your peripheries, you know, early signs of gangrene. Checking for a lot of diabetics have silent infarcts, having an acidity or a gas episode, which is mimicked as a gas or a nausea episode, a GI episode, which could be an inferior wall infarction, an early myocardial ischemia knocking at your door. So these are things which are picked up only if you're aware of it and you're in touch with your healthcare provider. So do that, and I think a lot of adverse events can be prevented.
Absolutely makes sense. One size cannot be applied to all at all. We are not a monolith. There are people who live in the cities and rural areas, younger people, older people, men, women, educated, less literate, people with comorbidities, and people who can afford and people who can't afford. So many, the heterogeneity of the population is so great that you can't have a population health thing and the personal diabetes care cannot be the same. And the population and also the person also largely dependent on the built environment also, where they live, pollution, all of those things have a big role to play nowadays. And we already talked about environmental, disruptors, especially, plastic and other things that are in the environment. So for the population, it'll have to be something that is doable and sustainable and something that or can be applied on a large scale, which I think will be education about food, healthy eating, physical activity, making the environment more enabling to do these things. Unless we have pavements and parks and places for children to play and schools that include physical activity, and unless we have those things, or even workplaces that allow, the HR should allow people to go and exercise, or unless we do those kind of things at a population level, we can't find the change. At a patient level, okay, we'll have to take it as one-on-one, one by one, and not one size fits all. We have to find out what their resources are, what their preferences are, what they can do, what their likes are, and then tailor a treatment for them.
What are the parameters important to consider before rehab of elderly patients having diabetes mellitus?
See, rehabilitation comes into picture when we have presence of chronic complications. More important is how we treat individuals who are elderly individuals with diabetes. Now, first thing is defining elderly. Now, there will be people who are at the age of 65, but are as compromised in terms of health as an individual at the age of 80 years. And there will be people who are at the age of 80 years also physically so fit that they compete with 65 years. So it depends on the overall health status, presence of comorbidities, the compromise on the cognitive function, the overall limitation in the physical activity, and so on. A person who is overall healthy, maintaining good physical activity, maintaining good mental faculties, normal cognitive function, generally, performing normal activities, even at the age of 80, should be treated like any other diabetes person. People who are having compromised health, having presence of multiple comorbidities, have already suffered a heart attack or stroke, or have severe neuropathy or kidney disease or cancer, in nutshell, have a reduced longevity, decreased longevity, or decreased life expectancy, then the overall approach to glucose control has to be lax. You don't want to get these patients into hypoglycemia. You don't want them to, these people may not be dependent on themselves. They may be dependent on somebody else to take care of their health. They may not be getting food on time every time. They may not be getting sufficient intake of water. They may not be, they may be having postural hypotension. So many factors you have to consider. So these people, you don't want to get them into hypoglycemia. You would like to avoid certain agents like SGLT2 inhibitors, which can cause, increased risk of falls. Excuse me. And you don't want to target A1C of less than 7%. Maybe you will give a A1C target of 7.5 or even 8% for somebody who's at the age of 85 and multiple comorbidities. But on the other hand, if somebody is doing well, maintaining a regular walk, say in the morning for 1 hour, functioning normally, maintaining a good work profile, having good healthy eating habits, normal cognitive function, no complications, can manage himself, can understand hypoglycemia, can monitor his sugars, is not dependent on people. So he can be advised as normal treatment strategy as we can do for anybody. So that is more important. Of course, then individualization of therapy is important, because somebody has neuropathy will have to be given different kind of strategy. Somebody has heart failure will have to be given different kind of strategy.
So elderly people having diabetes is a huge, I don't want to use the word challenge, because people who are older are extremely special and loved, and we should care for them. They need so many, I'm saying there are so many layers of complexity to this. We have to look at their resources. We have to look at, do they live alone? Do they live with family? Who is providing the care for them? We have to look at how fragile or frail or active they are, because all elderly are not the same. I know people in their 80s. My colleague who works with me in the clinic is in her 80s, one of them, and absolutely you can't call her elderly. So there are 80-year-olds and there are 80-year-olds. So we'll have to see what they are capable of. But when taking care of people with the elderly, we'll have to factor all of these things in. What can they afford? Who's taking care of them? What are their other conditions? What is their longevity like? They may have a condition that affects their longevity. What are their preferences? And then find a treatment. For example, I wouldn't prescribe something to an elderly person that can cause hypoglycemia or cause dizziness and falls. It'll be a little bit less of a concern if they are quite fit and ambulatory or have someone to take care of them. So all of those things is what I would look at. And very importantly, I would look at, can they afford it?
Elderly person with a diabetes have a lot of issues. It is a geriatric, multiple issues are there. It may be because of their denture problem, it may be because of their hearing, it may be because of their eyesight, it is maybe because of their position senses, it is maybe because of their muscle problems, it is maybe because of their joints, it is maybe because of their walking ability. So there are many geriatric issues are there with the elderly people. So if you are dealing with a patient with above the age of 65, 70, you also look for this geriatric issue, which are very, very important. Even their prostate, or the how many times person is going for urination, that's also very important, because sometimes if you are going to give a medication which can decrease the glucose level, a sudden hypoglycemia may lead to fall. Then how he is staying, who is taking care of these persons also, that's again important. If somebody is staying all alone, then you have to be more careful while dealing with diabetes and diabetes treatment. So treating a person above the age of 65 or 70, look for other comorbidity, and the comorbidity everything, and that decides your complete therapy, deciding the how you are going to treat this person. Even if he is alone and he can't afford many of the costly medication, that's also become a challenging issue for these persons to deal with. So in total, a elderly person require a medication which should not cause hypoglycemia. That's number one. So we should avoid the phone, and then we should see that how they can be monitored, a self-monitoring or using the insulin, a pain, whether they can use it or not. All these things are to be explained, and then there's psychological and behavior therapy, and then how much exercise they can do. This is also to be considered when you are dealing with the elderly person.
Let's shift our focus to diabetes in women, and more importantly, gestational diabetes. Should all pregnant women be screened with thyrotropin or TSH and thyroid antibodies, particularly TPO or microsomal antibodies?
So the current recommendation by the Indian Thyroid Society and I think FIGO is to do TSH. So we do a TSH, and if it is between 0.1 and 2.5, we don't have to do anything else. They're fine. If it is between, if it is above 2.5, you look at the anti-TPO antibodies. If the anti-TPO antibodies are positive, and if it's 2.5 to the upper limit of normal or the trimester-specific upper limit of normal, then you might, those patients can be considered for thyroxine based upon other things like previous miscarriages or family history or thyroid enlargement and conditions like that. But if they don't have any, and if they are TPO negative, that group between 2.5 and the upper limit of normal, we don't have to do anything. On the other hand, if they are TPO positive and above the upper limit of normal, which is usually 4 or a little higher than 4, depending on trimester specific, then we consider treatment for that group. If the TSH is more than 10, we treat everybody. You don't even have to do anything more. I still get antibodies because it tells me are they at risk for future postpartum thyroiditis and things like that. So it's a simple algorithm now. We don't need to do tests in everyone, all the tests.
Why not? Even for sugars, why not? I'm seeing a lot of gestational diabetes today. Why not? My simple take is, if a normal person who's driving, selling fruits on the road is undergoing health checkups today without visiting the doctor, it's become a common thing to not visit a doctor but undergo a full body comprehensive checkup. Where you check your arsenic levels, you check your selenium levels, you check your cobalt levels, something which we don't even do in an ICU patient. Admitted to the ICU in a critical condition. People are doing investigations which we have heard of only in forensic science. Those investigations are available cheap around the clock for everybody. Then why not these things? These are important things. So why just pregnant women should not undergo these things? And I think they're undergoing, right? The moment you're under a qualified gynecologist, they actually check for all these things. So they should be checked for, and they should be corrected early on in pregnancy, in the first trimester itself, not in the last trimester. So awareness is important, and they should be corrected.
We now move on to something that is a need and a newer technological advancement in clinical practice, which is telehealth. Will telehealth ultimately result in physicians delivering more care in terms of more visits or consultations, whether virtual or in person?
I think telehealth is here to stay. One of the good things that, if COVID, you can say, did anything good, one of the good things it did was that physicians learned that to embrace the technology. And more importantly, patients learn to accept it and learn how to use it. It's not, obviously, it's not for everyone. It can be made with the modifications, but it's definitely something that can, you can reach, as they say, the last mile. You can have more follow-up. The paramedical staff can be trained to be diabetes coaches so that, other than the visits they have with doctors, they can talk to them. Because I just want to end by saying that usually patients see, let's say, their diabetes doctor once in 3 months. And even if the doctor is really good and spends half an hour with them, that's only 2 hours in a whole year. The rest of the entire time, the patient is all alone. So telemedicine is something, can be a wonderful bridge between those face-to-face visits and their physician visits and the rest of the year, and could be a good motivational tool. And it's been shown, this data to show that outcomes are better.
Telehealth has launched in a big way because of COVID. I think the CEO of Microsoft, I think Satya, had made this wonderful comment. Pardon me, I should not be taking names here on a public platform, but I think it was this gentleman, who's a very respected gentleman in Microsoft, that the progress that information technology or computer science has done in the last 1.5 years is much more than what they could have done in the last 10 years. Because of COVID, the entire industry went into 7th and 8th year and turned out so much of valuable things like Zoom and Google Meet and all. They came up and we are conducting this meeting on Zoom sitting. I don't know where you're sitting, Dr. Amol, and I'm sitting in Mumbai, but we are having such a wonderful communication across the table as if we are sitting together. So telecommunication is playing a very important role. It has its advantages and disadvantages. I feel life में सब कुछ किसी को नहीं मिलता है, कहीं पे कुछ फायदे होते हैं, कुछ नुकसान होते हैं. But telehealth has a lot of advantages. You can get in touch with a doctor whenever you want, with appointment, which is easy to get in contact with a doctor. If a doctor has a very heavy OPD, you don't really have to wait for 6 hours and 4 hours in the consulting room for your appointment. You can take an appointment as per convenience of both the parties and get your consultation done with. You can connect with a doctor whom you want to connect. Probably if you're sitting in Mumbai, you can connect with your doctor in Kolkata. You can talk to a physician in US, a patient in US and Canada. A lot of my patients who are abroad are in touch with me on video consultations, and I have been able to correct their parameters sitting over here. That many things can be confidence building and reassuring a patient possible on a telecommunication. So telecommunication has bridged the gap as far as that time is concerned. Today, patients are also more busy than we are. Their times are also precious, and they would like their appointments to be met on time. So that is possible with the telecommunication. Geographic boundaries have closed. You can share files, you can share PowerPoint, you can share educational material, you can share reports and explain on a whiteboard, which Zoom is giving. You can actually draw and explain your concept in your mind much better than you could do across the table when you were physically meeting. The disadvantages, I always say, how can you heal if you cannot feel? That is, I write poems also, and one of the poems I've written, how can you heal if you can't feel? It makes a difference when you can reassure the patient by clapping on his shoulder. Maybe, sometimes a hug is required, shake hand is required, a physical contact, communication. As if you go through the manuals which HRs are given, 90% of communication is body language and 10% is verbal. That 80% body language communication is hampered in a telecommunication, especially if you don't have a good internet, broadband. If the video is not very strong, it affects over there. And, we learn so much from our movies, and people are crazily swallowing a lot of multimedia through, on the mobile, and people are practically walking, talking, eating on the mobile. So this is all telecommunication, right? So you can connect a lot with your patients on telecommunication, share a lot of information, build up a lot of confidence, do a lot of information exchange, which is not possible in a physical consultation. But like I said, some things can be done best in a physical consultation. So somewhere you're required to palpate the organs, feel the patient, feel their agony, treat them, put your stethoscope on them, which is not possible on a telecommunication. But if you're practicing in India and you're doing telecommunication, you have to be aware of the guidelines laid down by the government of India. There is a legal guideline laid down which few people are aware of. It's a PDF document that you must go through. Certain scheduled drugs, certain narcotics, certain sleeping medicines are not allowed to be prescribed on a telecommunication. It's a crime. You can be pushed up by the law if you prescribe it. So certain medications are not prescribable. You're consulting on a video consultation. You cannot do a WhatsApp consultation. That is not permitted by the law. It has to be recorded. You have to also verify the identity of the patient. We do telecommunications when the patients have put the appointment in somebody else's name and you actually end up doing a consultation with somebody else. So it's important that you check the government approved ID like the Aadhaar card or the driving license or something before you initiate and record it. And there are a lot of portals where a telecommunication is done, but the recording is not done. So patient confidentiality takes a backseat. In a physical consultation, you can give paramount importance to a patient confidentiality. In a telecommunication, you don't know who's listening on the other side of the story. And if you're not responsible, the information that is shared with you by the patient should not be shared with the common public. You cannot upload it on Facebook or WhatsApp, and you cannot share it with the people outside. So it becomes your responsibility to protect the confidentiality of your patient. So that is an important thing, and that has to be taken care of. And for your own medical legal protection, your communication ideally should be recorded and should be kept with you for future reference. There are a lot of portals which are available which do not give you this facility because the third-party portals are not allowed to record. Obviously, they cannot be a privy to your patient and your exchange of information. So you have to take the initiative to have your own system, which I'm doing. Like you can see, I have my own system which I've designed myself, where I can do video consultations on my own platform, and I keep a record for myself, which are not supposed to share because you need to respect the patient's privacy. And so there are a lot of advantages, there are a lot of disadvantages. I use both of them, and I will send a disclaimer to the patient that once the telecommunication is done, whenever possible and the earlier it is possible, come down for a physical consultation. I don't think a Google or any information technology can replace a doctor. It is not possible. And it's a good prelude to a physical consultation. Should be used to maximum potential, but should not replace a physical consultation.
Thank you so much. Thank you so much.
Thank you.
Thank you for having me.
Thank you, Doc Plexus, for this great interview. And thank you all my other panelists for participating in this. And today is World Diabetes Day. And we thank the Professor Banting, Sir Banting, for the discovery of insulin. And we hope that we are able to provide better and better care for our people with diabetes.
I would like to welcome and thank Dr. Madhu from DocPlexus for giving me this wonderful opportunity to connect with all of you on a global platform for holistic management of diabetes. I'm also honored and humbled by the presence of stalwarts like Makkar sir, Dr. Bansi sir and Usha ma'am, who would also be co-speakers on this wonderful summit. And I consider it as a big honor for me that I'm sitting with them and discussing the different aspects of holistic management of diabetes. It's a very good initiative, and I would like to thank DocPlexus for that. And I would like to thank all of you and all the audience which is listening. Wish you all the best in your life.
Thank you all the panelists here on joining us to better understand the holistic management of diabetes. DocPlexus, thank you for your time and efforts you took to share your thoughts and experiences with your community on the occasion of World Diabetes Day. A big thank you to all our dear audiences as well for their kind listening. Hoping this session would give you new insights in the treatment of your diabetic patients. We will see you soon. Until then, stay safe, stay updated, and happy DocPlexing.